Hi everyone, this is my journal presentation for Module 7 on the social cognitive theory. The article that I chose is titled Adherence to a Yoga Program in Older Women with Knee Osteoarthritis, and it was published in the Journal of Aging and Physical Activity in 2016, volume 24. So first, a little background. The health behavior that's being addressed is adherence to a yoga program, and the health problem they are addressing is knee osteoarthritis. In the article, the authors stressed that studies show that consistent exercise results in better outcomes in a therapy context. But they also noted that adherence to exercise programs is a common problem, and that this is especially true among older adults, and sometimes that's attributed to poor health and mobility limitations. In this particular case, we're talking about osteoarthritis, and that is the most common type of arthritis, and it's a common cause of disability and pain in adults. There is no cure for osteoarthritis, also known as OA, but exercise that improves muscle strength and balance is beneficial for treatment of osteoarthritis in older adults. Now some background on yoga in particular. Of course, we all know that yoga has become very popular in our Western culture. And it does improve strength, posture, balance, flexibility, as well as other things in older adults, and it's been proven in a clinical setting. And in this case, the authors cited a study by Field in 2011. Yoga has also been shown to relieve symptoms of osteoarthritis, and they cited 2 studies for that. They did say, though, that the relationships between yoga adherence and osteoarthritis-related outcomes are not clear. Most previous yoga studies didn't use a theoretical perspective. So, to bridge that gap, the authors chose to apply the social cognitive theory, otherwise known as SCT, because it has been proven to be effective in, and here I'm quoting directly from the article, initiating and maintaining behavior change to prevent and manage chronic disease, and for designing interventions that meet important practical challenges in public health. That's from page 181 of the article, and they referenced a study by Bandura in 2004. And you'll see who Bandura is in just a moment. So let's take a moment to look at the social cognitive theory briefly. I'm not going to go into too much detail because we have done that with the video lecture and also the chapter from our book. So just briefly, the social cognitive theory was developed under the leadership of Albert Bandura, as noted before, and it was refined and fully developed from his original social learning theory that he had developed in the 60s and 70s. And in fact, he renamed it the social cognitive theory in his book in 1986. It is one of the most broadly applied models of behavior, and it's used in a variety of contexts, both in the management and treatment of conditions and also in prevention. So let's take a look at the major constructs of social cognitive theory. The major constructs are organized into 3 categories, if you will, and we'll start with the first one, which is personal cognitive factors. Underneath personal cognitive factors, the constructs are self-efficacy, which is the confidence of the person in their ability to perform a behavior that leads to an outcome. And you'll notice I have self-efficacy in bold, and that is because in the study we'll be discussing momentarily, it is actually one of the things that is measured. Next, we have collective efficacy, which is a belief in the ability of a group of people to perform actions together to achieve an outcome. Next, we have outcome expectations, which are judgments about the likely consequences of actions. And the last under personal cognitive factors is knowledge, or the understanding of the health risks and benefits of different health practices and the information necessary to perform a behavior. You'll see that outcome expectations is also in bold, and again, that's because it is measured in the study. But collective efficacy and knowledge are not, and that is because they are implied or alluded to in the study, but they are not discussed directly, nor are they measured. Moving on to the socio-environmental factors, the next category, we have observational learning, which is learning new information and behaviors by observing the behaviors of others and the consequences of others' behaviors. Now, observational learning I have in italics because it is directly discussed in the article but not measured in the study. Next, we have normative beliefs, which are cultural norms and beliefs about the social acceptability and perceived prevalence of a behavior. Then we have social support, which is the perception of encouragement and support a person receives from his or her social network. And finally, we have barriers and opportunities. These are attributes of the social or physical environment that make behaviors harder or easier to perform. And again, that's italicized because those are discussed directly in the article. And finally, we come to the last category, behavioral factors. Underneath behavioral factors, we have behavioral skills, which are the abilities needed to successfully perform a behavior. We have intentions, which are goals of adding new behaviors or modifying existing behaviors, both short-term and long-term. And reinforcement and punishment, which is increasing or attenuating behavior through provision or removal of rewards or punishments. Again, reinforcement and punishment is italicized because it is directly discussed in the article. The other constructs are only implied or alluded to. So moving back to this study, the authors made it clear that this study is a secondary analysis of a randomized control trial that occurred in 2014, and they cited that actual study, which was by Chung and others. The original study was conducted to, and again I'm quoting directly from the article, investigate the feasibility, safety, and acceptability of using an 8-week Hatha Yoga program for managing knee osteoarthritis in older women. The purposes that were stated by the authors for this secondary analysis were to report yoga adherence during the intervention and follow-up period, the relationship between SCT constructs and yoga adherence, and the impact of yoga adherence on symptoms in community-dwelling older women with knee osteoarthritis who may have had pain, stiffness, decreased physical functioning of the lower extremities, their quality of sleep may have been affected, and also their quality of life, which is abbreviated as QOL. So let's move on now to the methods of the study, and we'll start with design. The number of participants was 36, and they were separated into 2 cohorts of 18. Each participant was assigned a random identification number from 1 to 36. Odd numbers were assigned to treatment group, and the even numbers were assigned to the control group. The intervention that they designed was an 8-week Hatha Yoga program, both group classes and a home-based program. The authors of the study designed in 2 categories of data collection. First, for adherence, they used self-recording log sheets for the 8-week intervention period, and then a survey at the 20 weeks follow-up. They also collected data on outcomes, so they started with baseline before the program started. They reassessed at 4 weeks into the program or halfway. Then they reassessed again at 8 weeks at the end of the intervention period, and then another assessment at the 20 weeks follow-up. Participants were given a $10 incentive at each data collection point, and here is where the study alludes to that reinforcement and punishment construct of the social cognitive theory. And then last, they wanted to stress that the protocol was approved by the St. Catherine University and University of Minnesota Institutional Review Boards. Now let's take a look at sample and setting. Participants were recruited several different ways. There were flyers placed in the community and at senior centers. They released a press release in the university's alumni newsletter and in local newspapers and senior publications. They mailed invitations to patients who met criteria that were in the University of Minnesota Physician Practice Database, and they gave health talks at community senior programs. The criteria that were required to be in the study were the following. The participants had to be community-dwelling women aged 65 or older. They had to have a diagnosed symptomatic osteoarthritis of the knee for at least 6 months. They had to have no previous training in any form of yoga and not be currently participating in any supervised exercise program. Osteoarthritis symptoms were assessed and confirmed by the principal investigator or a trained research assistant, an advanced practice nurse, using the clinical criteria for the classification of idiopathic osteoarthritis of the knee, developed by the American College of Rheumatology. And this is important because it did not require any radiographic evidence, meaning no X-ray, CT scan, or MRI needed, just the assessment. And there was a special note made that participants had to provide their own transportation to classes. Now let's look at the measures. First, we'll look at yoga adherence. To be considered a yoga adherer, participants had to attend at least 75% of the yoga classes, so 6 or more, during the intervention period. They had to practice at least 75% of the home yoga practice that was prescribed, and the prescribed practice was 90 minutes over 3 days per week, and that's during the intervention period. And then they had to practice at least 3 days per week, 20 minutes or more each time during the follow-up period after the 8-week intervention. Participants were provided a log sheet to self-record the frequency and duration of yoga practice, as well as any adverse events such as injury or worsening of symptoms. The log sheets only had the participant number to encourage honest reporting, and they were collected in a drop box at the beginning of each class. Participants were given incentives if they turned in 6 or more log sheets, such as yoga gear or water bottles. And again, we see here an allusion to the reinforcement and punishment construct. At the 20-week follow-up, they were given a questionnaire with 7 Likert scale items to assess frequency, duration, and pattern of home yoga practice. The questionnaire was reviewed for content by experts and tested with older adults for clarity and readability before the study ever began. Now let's look at the measures used for the social cognitive theory constructs in this study. As I mentioned in our brief review of the SCT, the only 2 constructs directly measured were outcome expectations and self-efficacy. For outcome expectations, they used the Outcome Expectations for Exercise scale, or the OEE scale, which measures outcome expectations and benefits associated with exercise in adults. It's a 5-point Likert type scale, with 1 being strongly agree and 5 being strongly disagree. The authors noted that the internal consistency and reliability was well established. For self-efficacy, they used the Self-Efficacy for Exercise scale, or the SEE scale. This measures self-efficacy expectations related to the ability to continue exercising in the face of barriers to that exercise. It's a range from 0, not confident, to 10, which is very confident. And again, the authors noted the internal consistency and reliability were high. Now let's take a look at the measures of osteoarthritis-related outcomes that were used in this study. The outcomes they looked at were in 4 different categories. The first one we're going to look at is OA symptoms such as pain, stiffness, and physical function. This was measured using the 24-item Western Ontario and McMaster University's OA Index scale, or the WOMAC. It is a 5-point Likert scale, with 0 being no symptoms to 4 being severe symptoms. And again, the authors noted the internal consistency and test-retest reliability were well established. Next, they looked at physical performance of the lower extremities, and they measured this using the Short Physical Performance Battery, or the SPPB. It has 3 components: repeated chair stands, balanced, and a timed 8-foot walk. The combined categorical score of the 3 components were measured from 0, unable to perform, to 12 being the highest degree of functioning. Next, they looked at quality of sleep, and they measured this using the Pittsburgh Sleep Quality Index, or the PSQI. It has 6 subscales that look at sleep quality, sleep latency, sleep duration, sleep disturbance, sleep efficiency, and use of sleep medication. A score greater than or equal to 5 on the total scale is associated with significant sleep disruptions, and this can include insomnia and major mood disorders. And lastly, they looked at quality of life, or QOL, and this was measured by 2 scales. One is the Short Form Health Survey, also known as the SF-12, which measures both physical and mental component summary scales, and the Cantrell Self-Anchoring Ladder, which measures both current and in 5 years life quality. They also collected at baseline age, education level, body mass index or BMI, and a number of comorbidities. And just in case there's anyone in the class who's not aware of what a comorbidity is, that just means other diagnoses that the person might have that may or may not impact their osteoarthritis. Now let's take a look at the intervention. As I mentioned earlier in this presentation, it is a Hatha Yoga program. And in this case, it consists of 1 60-minute Hatha Yoga class per week for 8 weeks, and additional yoga practice at home 4 times a week for 30 minutes per day during the intervention period. Now, with this intervention to promote self-efficacy, they used a small class size of 9 people, and it was specifically designed for older adults with knee osteoarthritis. The poses were modified and/or props were added, like a block or a strap, when needed to increase confidence and the ability to remain in a pose to obtain the benefits. And then to promote observational learning, the instructor was experienced in working with older adults and demonstrated all poses in the class and gave feedback to the students individually. And note that they did discuss here observational learning. It was not measured, but it was discussed as part of the study. Extra measures were taken to help provide an optimal learning experience and environment. Each participant was given a yoga mat on the first day to use in the group classes and at home. They were given handouts with pictures and written instructions on the postures after each class and to be able to use them at home. And the location of the classes was in a street-level building with enough parking in a quiet neighborhood near a bus line. So as you can see, these three items here are an allusion to two of the constructs in the socio-environmental factors, which are the social support, the first two, and the location is the barriers and opportunities. Obviously, they were working to kind of break down some of the physical barriers of the environment that might keep them from attending the class. Before the program started, the OEE and SEC scales were used to assess outcome expectations and self-efficacy, and then the findings were discussed with the instructor. Then, at the first class, the principal investigator addressed the common concerns that people have of exercise adherence. They reinforced the positive outcome expectations from the findings from the scales, and they provided strategies and incentive ideas to improve self-efficacy. And then to strengthen outcome expectations and self-efficacy, each class started with a 5-minute discussion of the specific issues and concerns the group had about yoga practice. Now, as you can see on this one slide, we are not only addressing the two constructs that were measured, outcome expectations and self-efficacy, but we also see an allusion to knowledge from the personal cognitive factors, the normative beliefs constructs from the social environmental factors, and also the incentives construct from the behavioral factors. Now let's look at the results. And we're going to start with some demographic data that was obtained as part of the study. It was a predominantly white population that was studied, 86%. The mean age was 71.9 years of age. The mean body mass index was 28.9. They had an attrition rate of 6%. That means only 2 people, and of that, 1 withdrew and 1 was disqualified for receiving cortisone injections. All but 2 of the participants completed their weekly home practice logs, and at the 20 weeks follow-up, all 34 completed the data collection. Now, let's look at the results just for yoga adherence first. During the intervention period, 74% of the participants attended at least 75% of the classes, which means they would be seen as a yoga adherer. And of the 75%, 12 of them, or 35%, attended all 8 classes. The average number of classes attended across the whole group was 6. 88% of the participants practiced at home at least 3 days per week, and 74% of them practiced at least 90 minutes per week total. So again, that would be considered a yoga adherer. The average frequency of home practice was 4 times a week, and the average duration of that practice was 114 minutes during the week. At the follow-up period, or 20 weeks later, 74% reported still practicing yoga at home for osteoarthritis management. And of that 74%, 45% practiced at least 3 days a week, which would be adherence, and 40% practiced at least 20 minutes each time. Again, that's adherence. And then conversely, 55% practiced 1 to 2 days a week, which would be considered a non-adherer, and 60% practiced less than 20 minutes per day, again, a non-adherer. Home yoga practice adherers by time and by number of days per week during the intervention period had a significantly lower body mass index and were significantly older. Home yoga adherers by time only had a significantly lower education level than non-adherers, and we're going to discuss that a little bit in the discussion section. Now let's look at the results for the social cognitive theory constructs. The baseline average OEE score was 13.7, which indicates a strong agreement to the positive outcome expectations for yoga. The OEE score, though, was not significantly correlated with class attendance or home practice. The baseline average SEE score was 72.0, which indicates a participant confidence that they would be able to continue practicing yoga in the face of barriers. Now, the SEC score was positively correlated with class attendance during the intervention period, but not during the home practice at any time point. And last, let's look at adherence as it relates to the osteoarthritis-related outcomes. So during the intervention period, regarding the classes, the group classes, there was found a moderate linear relationship with the changes scores. In other words, a difference from baseline and at 8-week assessments of the WOMAC subscales for pain and function and the total WOMAC score, and that refers to the osteoarthritis symptoms. Also, the balance subscale of the SPPB, which was measuring physical performance of the lower extremities, and sleep latency subscale of the PSQI, in other words, part of the quality of sleep that they were looking at. There were no correlations with either of the quality of life measures. During the home practice part of the home intervention period, there was a moderate linear relationship for average days of home practice with the SPPB chair stands, again that's physical performance of the lower extremities, the quality of sleep total score and the two subscales, particularly sleep quality and sleep latency, and the SF-12 mental health score for quality of life. There was also a positive moderate correlation for average minutes of home practice with the WOMAC function subscale and the total WOMAC scale for the OA symptoms, the SPPB global scale for physical performance of lower extremities, and the sleep quality, sleep latency subscale and the total score. So in other words, the quality of sleep. Then at the follow-up period at 20 weeks, they found positive correlations between participants who adhered to practicing yoga at home and the SF-12 mental health and Cantrell current score. So those are the two quality of life scores. So they saw a positive correlation if they were adhering to yoga at home and their quality of life. They did see also a negative correlation between the number of days of home practice and the PSQI subscale sleep duration and sleep medication use, and those measure quality of sleep, and we're going to talk about that again a little bit in the discussion section. Also, there was a positive correlation between the Cantrell current score and the number of minutes of home practice. So again, that's quality of life being measured. And all of the relationships above were listed as moderate. Now let's move to the discussion. Considering yoga adherence. Yoga adherence was high during the intervention period, but it decreased over time. And it's noted in the article that that's pretty common in any adherence to any exercise program. People tend to be very into it in the beginning, but then it kind of decreases over time. So some of the things that they discussed here that might have impacted that. The weekly group sessions may have encouraged exercise, which impacted home practice positively. So they might have been more willing to practice at home since they were doing the group sessions. The discontinuation of the classes might have contributed to the decline. So that's kind of the other end of that spectrum. The classes ended after 8 weeks, so during the follow-up period, they may have practiced less and less and less at home. The weekly log sheet might have been a reminder to practice at home, so that would be a positive, something they look at every day and say, oh, I've got to do my yoga now. Also, these classes were free, so the fact that they were free might have had a positive impact on class participation during the intervention period. Some things that they said needed further investigating: the group effects on exercise adherence, and also reasons why older women with osteoarthritis don't enroll in yoga classes. Now let's take a look at the social cognitive theory aspect. The high SEE scores were positively associated with class attendance. The number of days and minutes of home practice were not associated with either the OEE or the SEE at any point. And the authors state that this could be because the study was not really powered, yes, using their word, to detect such differences. And there are some factors that can affect home yoga practice, some barriers that should be assessed. And this is a quote directly from the article in the discussion about social cognitive theory as it applies to this study. Using the SCT framework to guide the implementation of the yoga intervention program and gathering OEE and SEE data at baseline contributed to the overall program success. And now we're going to look at adherence and osteoarthritis-related outcomes. So as they noted in the results, improvement in osteoarthritis symptoms, physical function of the lower extremities, sleep, and mental health moderately correlated with high adherence. A high number of days of home practice at follow-up moderately correlated with better quality of life, but also shorter sleep duration and a higher use of sleep medication. Now, they noted that the program was not specifically designed to improve sleep. So did the participants have an underlying sleep issue and they practiced yoga more days in an attempt to improve their sleep? That's not known, but that's one of the things that was posited. They also noted that 8 weeks of yoga may not be enough to improve sleep. And they said that further investigation is needed to explore the relationship between yoga and sleep. And then some of the demographics that they looked at. Adherers were older, less educated, and had lower BMI levels than non-adherers, as we noted in the results. They posit that being overweight is a risk factor for osteoarthritis and can exacerbate symptoms. In other words, pain and extra weight are barriers to exercise. So they believe that further investigation is needed to explore issues related to yoga practice among obese women. And then they talked about the education component. The higher education levels and younger age may mean that they are more active in the community and participating in other physical activities, leaving less time for home yoga practice. So that might be why we saw the result that adherers for home practice were older and also had a lower education level. So let's talk about the translation to health education and behavior practice. First, improving exercise adherence potentially enhances the treatment effect by maximizing how much of the intervention participants receive. So in other words, the more you do something, the more physically active you are, the better outcome you're probably going to have. So adherence equals getting more of the activity in. Exercise adherence is important for the success of any behavioral treatment, but no single approach has been found, say the authors, to consistently improve adherence, so a combination of approaches should be used. In older adults, poor exercise adherence can be caused by such factors as transportation limitations, the cost, any physical limitations that they may have outside of the knee area, any caregiver responsibilities they might have. At this age, these women might be caring for a spouse at home or in some cases potentially an older parent. And also depression. And while they didn't delve into depression as very deeply into this, they just mentioned it, I can tell you, working with the senior population, that is something that we do see quite often, that depression keeps people from wanting to be active. And these potential factors, say the authors, should be further investigated. They also note it's important to continue to try to better understand adherence and improve it in order to enhance treatment benefits, reduce the cost of clinical trials, and increase statistical power to determine the effectiveness of the interventions. So basically they're saying that we need to continue to try to understand the relationship between adherence to exercise, and particularly in yoga in this case, and its ability to decrease cost of medical care, to enhance treatment benefits and provide better outcomes for osteoarthritis and those sorts of things. Now, the authors did note some limitations with this study. First, the use of the self-report questionnaire could be affected by bad memories or social factors such as desirability and approval, and they're not as effective or as accurate as, say, a pedometer or an accelerometer. But then again, yoga can't really be measured by those types of devices because yoga is not as intensive a movement as, say, walking or running. They also noted that the sample was rather homogeneous, an example being primarily white, so to generalize the findings would be difficult. And then also, this was a pilot study with multiple comparisons performed among a small sample, so the authors say more research is needed to confirm the results. Now on to their conclusions. The authors concluded that social cognitive theory was a useful framework for reducing attrition in a yoga intervention trial in older women with knee osteoarthritis. And if you remember, the attrition rate was only 6%, or 2 of the original 36 people in the study. A higher frequency of yoga practice is correlated with improvement in osteoarthritis symptoms, physical function, sleep, and quality of life. Barriers to yoga practice and strategies for enhancing long-term yoga adherence need to be explored further. They also say that future research in this area should include larger and more diverse samples and should include adherence measures to determine its relationship to study outcomes. And lastly, the findings from this study provide an initial guide for understanding and improving adherence in future yoga research. So the talking points I would like to leave you all with. The authors of this study only measured 2 items related to the constructs of the social cognitive theory: self-efficacy and outcome expectations. Are there any other constructs that potentially could have been measured, and if so, how do you envision conducting that measurement? And then secondly, to what other health condition or conditions, or health behavior or behaviors, can you see applying the SCT in the way that this study does? But not least, of course, my resources were the actual study itself from the Journal of Aging and Physical Activity, and also our textbook, Chapter 9. I would like to thank you all so very much for your attention.